Great. I'm going to go ahead and get us started. Thank everybody for coming in today. My name is Mark Driscoll, and I am the program manager for the Preventative Health Program with the Ohio AAP. And I just wanted to take a moment to welcome you all and go over some of the etiquette for today's presentation before we get into the more informative portion. First, I have the CME disclosure. James Duffy, MD, MPH, FAAP, faculty of this educational activity has no relevant financial relationship with ineligible companies to disclose. And then a few things to keep in mind during the presentation. Please make sure that you are muted and stay muted until the end of the presentation. These slides and a recording of today's session will be posted on our Preventative Health Program website following the presentation. You will receive an email after the presentation about how to receive your CME and MOC Part 2 credit. If you have any questions, you can post those in the chat. Hopefully we'll have some time for question and answer at the end, and we can discuss some of the content questions. If there are any general questions that the staff from AAP can answer, we'll answer that as we go. Otherwise, I have the pleasure of introducing our speaker today, Dr. James Duffy. Dr. Duffy is a pediatrician and child psychiatrist with clinical appointments in the departments of pediatric and psychiatry at the Boonshoft School of Medicine in Dayton, Ohio. He is the immediate past chair of the executive committee of the Council on Community Pediatrics for the American Academy of Pediatrics and chair of the Medical Advisory Council for the Program for Children with Medical Handicaps at the Ohio Department of Health. In 2006, Dr. Duffy received the Healthcare Delivery Award from the Academic Pediatric Association for founding a comprehensive pediatric medical home in the historically under-resourced community in Springfield, Ohio. He was recognized in 2008 by the Ohio chapter of the AAP as the Outstanding Pediatrician of the Year, and in 2014 with the William H. Cotton Physician Advocacy Award. Now retired from clinical care, he works part-time as a consultant to the Bureau of Maternal, Child, and Family Health at the Ohio Department of Health. So welcome, Dr. Duffy.
Thank you, Mark. That was a lot of background, and I am pleased to talk with you today about three different programs really that push together and create a situation in which families and children can strengthen their relationships and solve some anticipated problems at sleep time, which is a common problem, and also some additional material about oral health and oral health assessment within primary care. Much of this I've talked about before in the past 2 to 3 years. There are videotapes or presentations, recorded presentations at the Ohio AAP website. So if we're going to go kind of quickly through this today, so we can have time for discussion at the end, you can always come back to either this presentation or one of the other presentations, particularly on oral health, because I'm going to kind of have a lot of slides, but I'm going to go through it fairly quickly. This is part 2 of a literacy series, and what I'd like to do is just talk a little bit first about relational health in primary care, and that's the next slide then, Mark. And you can go on to the next, because really what we like to do in primary care, and this is what I think is the early part, or what is going to happen to primary care next. We look at the evidence-based interventions. The evidence-based interventions in primary care are really two very particular ones. One is early childhood literacy, and another is vaccines. And the third probably is the promotion of relational health that provides the stability for relationships throughout a child's life, as a child and as youth and even as an adult. And throughout this process of brush, book, and bed, I want to remind you that the most important factor, the most important protective factor in the building of resilience in children is at least one safe and stable, supportive relationship with a parent or a caregiver or an adult. So while you're doing your primary care, while you're doing your advice and anticipatory guidance and teaching within this program, the main effort, really, the most important effort, is to promote the relational health of the child and security of the relationships between the child and the caretaker. Next slide, please. Supporting safe, stable, nurturing relationships and environments. Environments are really important. And this is something that can be done at any time. There are teachable moments, in the words of T. Barry Brazelton, one of my inspirations, and many others. Encourage self-reflection in parents and child and mutual activities, and keep the child in mind. That's a phrase that really means that a parent is able to understand empathically or with empathy what's happening in the child's life, and as the relationship develops in the context of serve and return, that the parent is able to understand the child's perspective, see the world from the eyes of the child. Next slide, please. And I'll just provide two quick studies to kind of prove the point, and then we'll get on to some specifics. This is one looking at cognitive ability and related to social economic status in children. And what we really see was that there was a ranking across the spectrum of reading and math, which you would imagine there was a sort of a distribution from 30% to 70% across quintiles. But really, what's important was what jumped out in the study was that the children at the top of the rankings were children with involved parents, and parents that provide expectations for achievement and provided school attendance. So really, the variable here that's extremely important is the involvement of the child with the parent, involvement of the parent with the child. Next slide. And you can even get very biological about it. And I'm not going to be biological today particularly, but if these are MRI studies, the hippocampus, and the hippocampus, of course, along with the medial prefrontal cortex, are really important areas for executive function and memory. And the hippocampus, particularly for long-term memory, and surprisingly, there's a maternal support is associated with. I'm not going to claim a causal relationship, but you can project maternal support is associated with hippocampal volume. The growth trajectory is associated then with later emotional functions. So early childhood stable relationships then actually can be measured by hippocampal size in childhood, and then associated epidemiologically with later emotional functioning and self-regulation. Okay, that's that part of the talk. So we're going to move on to brush, and I'm going to kind of move through this. I'm going to keep track of time so that we can have some time later on. The question is, what's the role of the primary care healthcare professional with oral health assessment? And clearly, the whole range is part of our scope now. And actually, when I trained, we didn't get much training about this at all, and we didn't have fluoride varnish, and we didn't have the sort of perspective that we have now about early childhood caries. But this is sort of the order of the next few slides, starting with assessment, and then the evaluation of the caretaker's oral hygiene. It's very important, once again, to talk about a two-generational approach. You need to be able to recognize the signs and symptoms of caries, and advise assess and advise the family about fluoride exposure, and then early referral to a dental home. And that's really most important for children that have early childhood caries. But we should try our best to develop a resource list of local dentists who are willing to see young children, as young as 1 or 2, as soon as they're able to be managed within a dental home. Next slide. First, just a refresher about oral flora. normal oral flora is colonized at tooth at the time of tooth eruption, but here's the critical point related to assessing the maternal oral health. It's basically mainly transmitted from the mother or the primary caregiver to the infant prior to tooth eruption. Let me say that again. The colonization occurs prior to tooth eruption, and the oral hygiene or oral bacteria, the biome, is transmitted from the mother or the primary caretaker to the child prior to tooth eruption. So even though it seems a little bit out of our scope in some ways, we have to be able to care for the child. We have to care for the mother. We think about that in many different ways with maternal depression and poverty and hunger and that sort of thing, but also very specifically with the transmission of oral flora, which many times includes the carriogenic bacteria, Streptococcus mutans. Next slide. There is a oral health assessment tool that's available, and I've provided the link there that practices can use if you choose to do documentation of risk factors and protective factors and clinical findings and assessment of plan. And that really can be helpful for communication, for instance, with the dental home when you're able to make that referral. And the next slide is another picture of that risk factor, or actually a risk assessment tool, and the link. Now you can't quite see it because of the format, but there is a in fact you can't read it, but there's an indicator for maternal oral health assessment. Next slide, please. Once again, I'm repeating because it's important. We take a two-generational approach, and the message to the mother is brush for two, and that comes from a very helpful program called Smiles for Life, and that's the link that you see on the page. Next slide, please. And here's a question: if you need to have sort of a script. Do you have swollen or bleeding gums, a toothache, problems eating or chewing food, or other problems in your mouth? When was your last dental visit? And do you need to help finding a dentist? And this is a program that the obstetricians are implementing, but we need to implement that, particularly when we have parents or families in our practices that are having a second or third baby, or unfortunately, in many circumstances, when we have teenagers who are pregnant, we part of our scope of practice and part of our responsibility obligations is to assess the oral health of the mother, in this case, or the primary caretaker, in order to advise appropriately to improve the oral hygiene of the child. Next slide, please. And here's sort of I altered this a little bit, but it comes from a nice article by Featherstone from 2007. We have disease indicators on the left, which is caries progression with brown or white spots, and we'll talk about that in a minute. And I'll show you some slides, and you've probably seen many people have seen this. But on the other end are the protective factors of saliva, sealants, and fluoride varnish, as well as diet and oral hygiene, and the availability of a dental home. In the middle there, the risk factors. Maternal caries is number one. Carriogenic bacteria transmitted from the mother or primary caretaker, and poor diet, particularly sugar. Sometimes medications. Mark mentioned that I've been involved with children with special health care needs, as many of us have. The children with medical complexity, in particular, that take regular medication 2 or 3 times a day, and anticonvulsants and other medicines for spasticity or other neurologic related treatments. often have terrible caries, and there are very few people that will accept those children who have difficulty opening their mouths, that have difficulty with chewing, and sometimes are given on a regular basis sugar-containing medications, liquid medications. Next slide, please. A reminder about the pathophysiology of caries. It takes three things: the substrate, and the morphology of the tooth, and the oral flora, particularly Strep mutans as the primary cariogenic bacteria. Next slide. The problems with early childhood caries. This is if somebody asked you as a pediatrician or a pediatric clinician, what's the most common most common chronic infection in childhood? I think very few people would think caries, but that's exactly what it is, and this is the most common chronic infection of childhood, and it causes significant morbidity, which you can read on that list. And children that have dental decay also have dental decay as adults. Next slide, please. And here's the prevalence. You can read the numbers, but I think it's easier to remember. It's 5 times more common than asthma, and 7 times more common than allergic rhinitis. And you know how often we see children with reactive airway disease or allergic rhinitis. 5 to 7 times more common are early childhood caries. Next slide, please. As I mentioned, one of the high-risk groups is children with special health care needs, but there are other high-risk groups, including children with suboptimal exposure to topical or systemic fluoride, children with low resource community who are living in low resource communities, and children who are food insecure, essentially, and those who have for other reasons have poor dietary and feeding habits. Next slide. Here's some pictures of healthy teeth. Most of these are children beyond the age of 5. Maybe we see up in the upper left-hand corner. Those may be primary teeth. The rest of them seem to be like secondary teeth. Perhaps the lower right, but I think that they're mostly secondary teeth. Well, the lower right, maybe not. Next slide, please. But here's the early part. These are white spots, early signs of decay. Actually, some of them are brown lesions. Some of them are white spots, plaque building up along the gingiva, particularly in a couple of them. But those little brown spots next to the white spots are early signs of decay. And if you see that, there are things you can do. In particular, fluoride varnish is helpful to reverse those brown spots. But if it progresses, next slide, please. It progresses further, and you see a lot of loss of the enamel, and particularly along the gingival lines, and some gingival swelling, gingivitis, periodontal gingivitis. This is difficult to reverse. You still can manage to a certain extent with topical fluoride varnish, but I think this requires referral to a dentist. Next slide, please. And this is what we used to call bottle caries. This child has loss of dentition along the front incisors, up at the top of the mouth, and that's probably because the child was put to bed with a bottle that had some sort of sugared liquid in the bottle, either milk or Mountain Dew or some other variation of that. Next slide, please. I've gone over this already with children with special health care needs, or children with medical complexity, particularly children with SMA or some sort of one variation of cerebral palsy. That it's really important to assess the oral health, but also assess the medications and choose non-sugar containing medicines uh, for chronic conditions. Very, very few dentists will accept these kids, and so developing a relationship with one of the medical centers and the oral surgery and the dentistry programs at one of the medical centers would be really important. Next slide. You are what you eat. This is fairly straightforward. Caries is promoted by carbohydrates, which break down to acid. Acid causes demineralization. Sugary drinks promote acid attack. And the important thing is then fluoride varnish then mineralizes the enamel. So you can prevent problems to some degree with fluoride varnish application. And you can reverse some of the early signs. Next slide, please. There's you brush for 2, and children younger than 3 should have a smear of toothpaste about the size of a grain of rice, and 3 to 6 should use a dab about the size of a pea. Next slide, please. Flossing, we don't think about flossing a whole lot, but once their 2 teeth touch each other, it's time to start flossing, and that can be a fun activity. It can also be a tremendous struggle, but if you start early and it becomes sort of a game, and it's that serve and return, that's smiling and the smiling back and laughing, it can be a pleasant experience, particularly if it starts early. Next slide, please. We've talked about this before. The community water should be around 0.7 milligrams per liter. Community water fluoridation has been very effective, although there's been resistance in some communities. The community that I practiced in, Springfield, Ohio, was the largest metropolitan area in Ohio that did not have fluoride in the community water supply, and in about 2004, earlier than that, 2003 or 2004, we were the first program in Ohio to apply fluoride varnish to preschoolers. We brought the program to Ohio and worked with the Ohio Department of Health and Medicaid to set up reimbursement for fluoride varnish. Next slide, please. Here's a sort of a general map of where you might see fluoride in the groundwater, and you see Appalachian Ohio really has no fluoride in the water. Up in the northwest, there may be more fluoride, which means you may not want to use a supplement in those areas. Next slide, please. And here's a graph recommendation for fluoride supplementation based on the community water fluoride or the groundwater fluoride. This is a lot of this is for rural areas, but it's really important to check with your local water supply in your own community to know what the level of fluoride is in the local water. Next slide, please. And this is the introduction of fluoride varnish. I won't go through this in particular. I have a couple of links later on, but I will say that it's topical. It's not associated with fluorosis. It's safe, effective. It's very little of it's absorbed, and it's easy to do in the office. Next slide, please. And it reduces actually 25 to 45% reduction in early childhood caries. It's good. It starts with tooth eruption, and every 6 months thereafter until at least the age of 3, sometimes the age of 5. It's effective on white lesions. The 25 to 40% reduction may be low. I've seen studies as high as 60 to 75% in European studies. Next slide, please. And here's a slide about payment. The CPT code is 99188. Next slide, please. I have two slides about anticipatory guidance. I'm not going to go through them because I've talked about a lot of them. I will say that back up one time, Mark, please. The one time I saw a 10-month-old or so with a sore throat. Well, that looked like tonsil pharyngitis, and I swabbed the child, which I generally don't do, and it came back positive for strep. And I looked at the mother and said, you know, I don't generally see strep in this age group. I had sort of a little brain fade and said, I could generally wouldn't be this confrontational, but I said, you know, have you been cleaning the pacifier that he drops on the floor by putting it in your mouth? And she said, no. But then she looked at me and said, well, I have been chewing his food. and she felt like it was important for the toddler, or the actually a 10-month-old, to have meat in his diet, and actually was chewing the meat in his diet, chewing the meat and then taking it from her mouth and putting it in his mouth, and thereby causing the strep and the strep tonsil pharyngitis in the child. So these anticipatory guidance recommendations really are important, and they sometimes are you know, I don't know what to say about that. Anyway, let's go on. Next slide, please. And a referral to the dental home. The recommendation is by 6 months, and all children by 1 year. That's the AAP recommendation, but it's completely unreasonable. We don't have dentists that will accept 1-year-olds very, very commonly. So, but it's not a bad thing to talk about the gold standard. That's what should happen, but it doesn't happen very often. Clearly, what we'd like to do is for community practices to develop relationships with local dentists to refer as soon as possible. Next slide, please. And here's the clinical flow. And we had a question last time about the clinical flow about reach out and read, and I'll get back to that. I think we're doing okay. We're about half done, and we've gone 30 minutes. The clinical flow for Fluoride Advantage would be that the medical assistant then identifies eligibility and gathers the supplies and provides the handouts and notifies the nurse. And during the visit, I think probably the best way is that because children are generally sensitive about their mouths and their tactile defensive, so having the fluoride varnish application done usually last. And as you can see in the picture in the upper left, I was a nurse practitioner that I worked with 15 years ago or so, and we started doing this, or 20 years ago. And she would the baby would start with hugging the mother and then face to face, and then the child would kind of lay back on the nurse practitioner's lap, and the nurse practitioner would apply the fluoride varnish. And then obviously the post visit would be documentation and submitting the code. Next slide. Here's a couple of resources out. The Smiles for Life actually has a smartphone app that I'd recommend. The link, the first link is from the Ohio Association of Family Practice, and it's a good article. Lifting up the idea of doing fluoride varnish among family practices in the medical home and advanced medical home. Okay, next slide. These are oral health resources from the Ohio Department of Health that we can make available. Next slide. Now, let's move on, and I'll just have 2 or 3. Again, this was This was thought to be part two of literacy promotion. Now, this is how literacy promotion fits into the nighttime routine, and it can have multiple effects. Um, so, just as a recap, the literacy promotion is an essential component of primary care pediatric practice. As I mentioned earlier, I think there are very few parts of our primary care strategy that have clear evidence. Vaccines are one. Early childhood literacy promotion is two. The promotion of relational health is three. There may be others, but those are three, without a doubt, have evidence, and we all should be doing this. Um, Next slide, please. In addition to Reach Out and Read, then the Dolly Parton's Imagination Library, and this is the slide that you saw last week, just to kind of pull it forward. The interesting thing about Dolly Parton's library is that it's for all children, and they don't really stratify by development, the books come to the houses, and so we kind of make the house literacy rich, but it doesn't replace Reach Out and Read. As you heard last session, the combination of the Imagination Library and Reach Out and Read is strong. It's better than either one alone. Although I personally, if I had a choice in a primary care practice, I'd choose in the practice, I'd choose Reach Out and Read. But there's no question that the Imagination Library, just putting books in the house, there's so many families that just don't have any books, don't have any magazines, and it piques my my interest to say to you that just like assessment of oral hygiene of the mother or the caretaker is important, it's also important to assess the literacy, particularly health literacy level of the parents. And many times that you can keep a resource list available to refer parents for literacy or for English as a second language, to encourage the parents to improve their literacy so they can improve their child's literacy. Some recommendations for 9 to 12 months. Next slide, please. And further recommendations for 12 to 18 months. This is, remember, I mentioned serve and return earlier, and that's really the serve and return is an important, it's kind of like peekaboo. It's something that happens at 9 or 10 months with a peekaboo game, but then later you can say, "Where's the doggy?" and the child can point to the dog. You say, "Great job. Where's the cat?" or "Where's the happy baby?" So this is the way that babies learn to interact and to have meaningful language in the context of literacy, but also develop that strong reciprocal relationship between parent and child. Next slide, please. Now, I'm going to hold up this book. You see that book on your screen there, and that is my father's reader. That's how he learned to read, and because it was Eugene Field was a poet around the turn of the century, and this book was copyrighted in 1920, although it was the earliest was copyright was about 1890. And my dad learned this, and I just want to make a little transition here to the relational part of literacy and read a little bit of Wink and Blink and a Nod. I'm just going to read the first and the last to show you what it means to put books in the context of relationships. Winkin', blinkin', and nod one night sailed off in a wooden shoe, sailed on a river of crystal light into a sea of dew. Where are you going, and what do you wish? The old moon asked the three. We have come to fish for the herring fish that live in the beautiful sea. Nets of silver and gold have we, said Winkin', Blinkin', and Nod. And then there are a couple of stanzas about their experiences in the twinkling foam and down through the skies and the wooden shoe, the bringing the fisherman home. And then the last stanza says, and it's sort of like the Greek the Greek dramas in which the narrator eventually turns to the audience and says this: "Winkin' and blinkin' are the two little eyes, and nod is the little head, and the wooden shoe that sailed the skies is a wee one's trundle bed. So shut your eyes while mother sings of wonderful sights that be, and you shall see the beautiful things as you rock in the misty sea, where the old shoe rocked the fishermen three, winkin', blinkin', and nod." So you can see that literacy, and particularly nighttime reading, is relational. It's to build the relationship. You can imagine that the mother is reading about the dream life of the children, and providing that secure, or the mother, a caretaker, the father, that could be reading to the child and allowing the child to feel safe and secure as they go to bed. And that quote from Eugene Field: "No book can be appreciated until it has been slept with and dreamed over." That's amazing. Next slide, please. So here's the power of routine. The power of the bedtime routine is not what you do, but how you do it. You set the pattern every night. You brush, you do the oral hygiene, and then you read, and then you move on to a bedtime sequence. Next slide, please. When you in your bedtime advice, of course, I need to remind people about safe sleeping alone and on the back and in a crib. You know, I was on the faculty for a while at University of Virginia, and that's where the work was done to change how we put babies down. When I trained in the nursery, babies were still put down on their bellies, and clearly the epidemiological studies were done in about 1990 or so, and they looked at babies in the United States put down on their backs, or sorry, babies in the United States put down on their bellies, and babies in Europe put down on their backs. The Europeans were correct that babies put down on their backs died of crib death, to use a general term, at about half the rate of babies that were put down on their bellies. So from the mid 90s on, we've been putting babies down on their backs, and yet anybody who's served on a county child review committee, child fatality review committee, know that we lose children every year, lose babies every year because of overlays, because of strangulation, kids falling through one of the railing cracks. There's strong pushback from some of the breastfeeding organizations, for instance, about co-sleeping. Our recommendation, without any qualification, is ABC, alone on the back in a crib. Next slide, please. Bedtime fussiness. We can come back to that if we want to talk about it a little bit more, but the main thing is that we don't respond right away. Responding right away to bedtime fussiness is a way to reinforce the behavior. It's as simple as that. We need to assess whether or not the child is sick or has something poking into them. Back in again in my day, we actually used bobby pins to pin up the cloth diapers, and there were times when the bobby pin came out and was poking into a child. So I'm not being flippant about it. I think we do need to assess the child when they're fussy at night, the infant, and yet overreactions and more frequent reactions may be actually reinforcing the behavior. So we need to one thing is to wait a few minutes, but the other part that I've talked about here is what's called a transition object, or a blankie, something that smells like and looks and reminds the child of the parent. It could be even something as simple as an undershirt, a mother's undershirt or the father's undershirt, that is in with a little bit older child, not with an infant. I'm talking about an older child now. Could have old enough to have something in the bed and have something that could be a security a link to the parent after if they suffer night awakenings. Next slide, please. The same sort of idea with ADHD and the kids on the autism spectrum, but in particular the routine is a cornerstone of management. And I want to mention in particular to limiting the exposure to TVs and blue light computer screens for at least an hour before bed. Next slide, please. There are a couple of a couple of books that could be used for nighttime fears. In particular, there's some evidence for the use of Uncle Lightfoot flip that switch, and that evidence has actually been the book has been translated into a number of languages. And I saw an article that was actually, I think it was Hungarian, that there was a study that actually showed a reasonable improvement with nighttime fears with the use of Uncle Lightfoot. There's another one. There's a couple of them from the United States. I think the University of Michigan, as I recall. The Berenstain Bears. That's the book that we used with our kids, and you can see that the strategy of using a nightlight. Next slide, please. And once again, I've been emphasizing the relational component. This is the bilingual book that shows the mothers and babies, and it says very clearly, I love my mommy because she is not afraid of the dark. Quiero a mi mamá porque no tiene miedo a la oscuridad. That's a great book. Next slide, please. Okay, so it's about 10 after 1. We have a few minutes to talk about the implementation and a few minutes for questions. Implementation of brush, book, and bed. One is you need to have a buy-in from your practice and coworkers, obviously, and a champion that will coordinate the program. Training for staff, and I would say particularly training for all staff about, I mentioned that one other time that recently that we used to close the place down for a couple of days a year just for all staff training. We include coding and billing and particularly all the front end people to not only include them because they all had a lot of them had kids and benefited from the training directly, but indirectly by understanding what we were doing as clinicians and being able to coordinate the total body or total organization effort. To be able to evaluate, I think all of you know what a PDSA cycle is, plan, do, study, act cycle, to find out what works best for your particular office. And I think it's really an important strategy. It's an easy strategy, but it's formalized and it can tell you a lot of information about what's working for your particular situation. Next slide. Then it's establishing referral sources and relationships. Often it doesn't have to be a nurse, but somebody in the office who knows the local community better than anybody else. It could be a receptionist, could be a nurse, could be a medical assistant. That is your go-to person about referrals and referral sources, and that person puts together a book of referrals, that referral sources of locations, and is able to step in. Now we do that particularly for food insecurity as well, and for other things that are related to community coordination for all the kind of child serving organization within the community. But for this particular program, Brush Book and Bed, it's important to establish those dental referral sources, but also literacy sources for early childhood literacy, coordinating with the schools, particularly once kids are in the 3-year-old range, to be able to transition to from early intervention to preschool. Um, you may need to look for sources for donations, and partnering with the community organization in that area is extremely important, particularly for books. Sustainability is the other side of that coin, and then you evaluate. Next slide, please. The clinical flow then occurs. I talked some about the fluoride varnish, but this is sort of the general idea that the medical assistant once again determines the eligibility and alerts everybody about the eligibility for Brush Book and Bed, and then gathers the supplies together and documents his or her activities in their record. Now, that's particularly important for Reach Out and Read because their books are developmentally appropriate and sometimes linguistically appropriate, because we have kids in Springfield right now that have a lot of folks from Haiti, for instance. So Haitian Creole is the new language. When I was in practice, it was Spanish, because we had lots of migrant farm workers originally, and then 12-month residents that were coming to our FQHC. Next slide, please. And so during the clinical visit, you discuss the program, you discuss and provide oral health counseling and risk assessment, you use the book for early literacy assessment, discuss bedtime routine, and recommend fluoride varnish. Next slide, please. So you can do a program evaluation pretty easily, just the process evaluation. Some people, and the important part of this is if you're looking for money, if you're looking for a United Way, for instance, a small grant to help you with fluoride varnish, or if you're looking for a larger grant, like with one of the local grocery stores or department stores that are willing that have a small operation, a small foundation that can provide books. It's important to have some evidence. So this is not really evidence of effectiveness, but it's evidence of implementation. So it's a process evaluation. A couple of suggestions that I make is the percent of the total number of children under 5 who receive a book. Simple. How many books do you give out in a year, and what percentage of the children? And then you track it over. You do a run chart. For the first few months, it may be only 25%. For the next, it could be later. It could be up to 100%. And particularly with fluoride varnish, what are the percent and the total number of children under 3? Those are easy program evaluations. It can actually be done with a chart review if it's all referred. The other one is the resource list for a dental home referral, and that's much trickier. And that can be used as a needs assessment for your community. If that number is very, very low, and you can identify the need, and it can be part of essentially a strategy you can involve the health department, other places that may be willing to provide incentives to attract pediatric dentists into the area. You can also do post-visit parental surveys and look at the change over time. Did so-and-so, did the clinician discuss bedtime routines, for instance? That's kind of simple. Next slide, please. Here's some sample post-visit questions. I won't go through that because we will have some time to talk a little bit. But the main thing is to not only ask the question, but what changes over time, in your office and also in your homes of your family. Next slide, please. But the final mention is all about relationships, and my friend Lance Chilton, who is also the chair of the executive committee of the Council on Pediatrics, Community Pediatrics. It's one of his grandkids. He's on the left, your left. Uh, I kidded him because of sometimes he thinks he's a late bloomer. But if you look at the one on the right, was one of his friends and who lives close by in Albuquerque. And the name of that little book is General Relativity. It's amazing. It's amazing. All right, but it's all about relationships. You see how the kids are. They have mutual focus. They're working together. They're learning together, and the closeness is extremely important. Next slide. And that's all. That's all that I have for today. I went fairly quickly because I think we have about 10 minutes or so. Do we? Yeah, maybe about 9 or 10 minutes for discussion or questions. Thank you for your attention. I hope that this has been helpful, and I hope that you consider implementing the whole routine, because I think as a package, it not only improves children's lives by avoiding early childhood literacy, but it also, early childhood caries, but it also promotes early childhood literacy, and it reduces stress around bedtime, which is often a very difficult problem for families and creates difficulties between children and their caretakers. Thank you very much.
Great. Thank you, Dr. Duffy. We do have time for questions. So if you do have questions, if you don't mind putting those into the chat, I can see those easier than raising your hand. I will mention that Lori from Reach Out and Read mentioned that you can find books about oral health if you're part of a Reach Out and Read site. You can make that some of your library as well. If there aren't, oh, go ahead.
I'm going to ramble. I'm going to ramble then. I'll ramble a bit because I want to emphasize that, I showed you my father's reader, Eugene Field reader. My aunt had a reader that was the Hiawatha reader, and I've been always interested in the fact that children these days, the state even worries about phonetics and things, strategies to read, but it's really all about relationships. Children learn to read when they want to read, and when it's meaningful for them to read. When it's not meaningful, it's not. And my father and my aunt grew up with literature that was written actually for adults, and so it was meaningful. It was for adults, and it was relational. Remember, the Hiawatha reader was all about Longfellow's poem, and remember that it starts out by a lake in a hogan or a wigwam with a young boy and his grandmother. So it's a young boy and his grandmother, and then the Eugene Field reader is the young children and their mother reading at night. So it's all about relationship. Literacy is all about relationships. It bothers me a tremendous amount when I see modern readers that have stick figures. In fact, when our children grew up, one of their readers, their series, I have 6 books, I think, in this series, and there are no humans, there were no adults until about the 3rd book of the series. They were all stick figures. And in the 3rd book or so, the first human that showed up actually was the kids were playing in their red wagon, and the red wagon was left in the front yard. And the first adult that showed up actually came and took the red wagon, thinking it was a piece of trash, and they took it away to fix it up and sell it in a junk store. So the first adult was a thief, um, and didn't respect the common industry of the children. So I just wonder how we can affect that sort of that lapse in our practice, in our pediatric practices, by making sure that books are part of the relationship between among the children and the caretakers, and so that it becomes meaningful. It's not just abstract. It's not just a skill that's apart from those relationships. So that's my ramble. This is
This
the
kind of, we had a
this is the
question
high,
come up.
this is the Hiawatha reader. That's my aunt, and this is my father's, the Eugene reader, the Eugene field reader from the 1920s, 100 years ago. Go ahead.
We did have a question come up that kind of tags along with that. It mentioned that there was a study that showed that over 50% of parents did not have a bedtime routine, and they stated that this is obviously routine is important for book or brush part of the presentation. Do you have any thoughts on that?
Well, I think Laura, you've mentioned, you could give your thoughts, but certainly is is a source of stress for families that is fairly easy to overcome. It takes about a half an hour or so each night at the same time. It's very clear that a lot of kids don't have clear bedtimes, and many children have, and teenagers have electronics in the room, TVs in the room. That's certainly affects their sleep, and that affects their school performance, and it ultimately is associated with depression and anxiety. So, time to start thinking about this, Lori. Thanks for the prompt, and this is one of the solutions. Start early.
Great. I'll kind of take that as my cue to wrap things up. I first definitely want to thank Dr. Duffy for a wealth of information and a great presentation. A few things from, oh, go ahead.
No, I'm just reading a comment from Marie Doan. You want to read it?
Yes. I'm a Mima, and when I would babysit my grandsons, they would love to hear stories of their mom as a child, and I would show them baby pictures and pictures of them growing up and tell the story like it was a book.
There you are. And I think it's often effective when you have a poem or a story to substitute the child's name for the name of the protagonist in the story. There's a book called Mickey in the Night Kitchen, I believe, and we read that story over and over again, but changed the word to Mikey because that was our son's name. So he thought he was in the book and he was in the night kitchen. So changing things around and making it part of yeah, there you are. Yeah, there you are. Vietnamese and Irish.
Personalized.
That's right. Without a doubt. Thank you.
Great. I'll just mention a couple of things as we close out. Once again, I will be sending an email for the CME and MOC Part 2 credit. The slides of this presentation, as well as the video, will be posted shortly here in the next few days. There will also be a resource that will be a handout resource available for you to use in your offices as well. Just a couple of kind of plugs here. We do have two pieces of education coming up in January. The first of those will be on Wednesday, January 24th, and that is about screening for maternal depression at the Well Child visit. Also eligible for CME credit. You can register at that link when I post the slides or use this QR code. And then our Parenting at Mealtime and Playtime program also has a webinar coming up on January 31st at noon. This is about navigating difficult weight-related conversations. And that one's also eligible for CME and MOC credit. Otherwise, again, I want to thank Dr. Duffy for a great presentation and hope that you all have a wonderful rest of your day. We'll see you next time.
Thank you.